Hi, and welcome to MedInsights Unleashed podcast. I'm John Collins, and I hope you enjoyed this new episode, and thank you for listening. Welcome to MedInsights Unleashed. Throughout this podcast, we've discussed continually the importance of the multidisciplinary team in caring for patients. However, one area that we've never explored in depth is the vital role of rehabilitation. I first met Kelley Wood while discussing her research at the ASCO Annual Meeting, and it quickly became clear to me that rehabilitation was a topic that we needed to cover for our listeners. Cancer rehabilitation is becoming an increasingly important part of the comprehensive cancer care, helping patients maintain their function, improving their quality of life and recovery throughout every stage of their cancer journey. Today, we will discuss why cancer rehabilitation matters, the evidence supporting early intervention, and how rehabilitation is improving the outcomes for patients and survivors. I am delighted to welcome Dr. Kelley Wood, Director of Research, and Dr. Alina Hedaya, Program Director from ReVital Cancer Rehabilitation Program at Kessler Rehabilitation Center. Kelley and Alina, welcome to MedInsights Unleashed. Can you briefly introduce yourselves and tell our listeners about the role that you have in cancer rehabilitation?
Sure, John. Thanks for having us. We're excited to chat with you today and your audience about cancer rehabilitation. This is a field that's very near and dear to both Alina and I's hearts. And so we're excited to chat with you. So I'm Kelley Wood. I'm the Director of Research for ReVital Cancer Rehabilitation. And while we are at Kessler, we're actually a national rehabilitation program. So we're the largest and leading rehabilitation program in the United States. We have about 1,000 physical therapists, occupational therapists, and speech language therapists who have been specially trained to understand the role of rehabilitation throughout the cancer care continuum, to understand the impacts of cancer care really across the entire patient's, body and mental and physical aspects. And so that's really what we do, is providing cancer rehabilitation across the country to patients across the cancer continuum. And then my role is to perform research on the program. So primarily like large scale health services research, really generating the evidence that we need to justify the value of cancer rehabilitation services, because this is a relatively new field still. It's been pretty well established for the past 20 years or so now and growing. However, there's still a lot of work to be done in terms of the evidence that we need to continue to improve access across the country and the world. And then also the evidence we need, particularly here in the US, to continue to improve reimbursement for these services so that more and more patients can have access. So that's the kind of the work that I do. And like I said, we're really happy to be here today talking to you about cancer rehab.
Great. And thanks, Kelley. And Alina.
Hi, I'm Alina Hedaya. I'm a physical therapist. I serve as director of the ReVital Cancer Rehab program at Kessler in New Jersey. And, I'm really passionate about integrating rehab into oncology care. It is part of the fiber in orthopedic care. It is part of the fiber in neurologic care. And it is still highly underutilized in oncology care, where there are predictable side effects, short-term as well as long-term, that we know patients experience during the treatment of cancer and after. And rehab is the profession that truly focuses on people's function and making people independent. So my role is to increase access to this type of care internally, to support our clinicians, to make sure we're delivering high quality care, that everyone has the latest evidence-based information, and externally educating providers, oncology teams, surgical teams, community members that these services exist and how to access and how to integrate them into workflows so that rehab isn't an afterthought, but it's integrated every step of the way throughout the continuum, as Kelley mentioned.
Thanks very much, Alina. Kelley, we met at ASCO. Your research highlighted the importance of cancer rehabilitation. For the listeners that may not be familiar with this field, what is actually cancer rehabilitation? What's involved? What's the awareness?
Yeah, it's a great question, John. So I think Alina said it very well, and most people are familiar with rehabilitation in the context of a musculoskeletal injury or perhaps a joint replacement or neurological condition, for example, a stroke. And rehab is really, like Alina said, part of the fiber in the multidisciplinary approach to recovery from those injuries or chronic conditions, whatever that may be. And so in cancer care, we know that cancer treatment doesn't just affect the cancer itself. It impacts the entire person. 60% or more of cancer survivors experience some aspect of functional decline. This may look like a broad array of different sort of aspects, everything from fatigue, pain, which may become chronic if not treated, also difficulty doing activities of daily living. There's just an array of ways that can sort of present itself. But the goal of rehabilitation is to help folks to deal with those physical issues and to not only recover their health during and following treatment, but recover their function as well. So like Alina said, rehabilitation, we're really are focused on patients functioning, really from a holistic perspective. So it's all about helping patients to be able to do their daily activities, whether that be work, caring for their children, their home, regaining strength and endurance during and after treatment. So that's really the focus of cancer rehabilitation. What it looks like is it's typically delivered in an outpatient setting. At least that's the work that we do at ReVital. So just like you would go into rehabilitation after a knee replacement, it's primarily physical therapists, although we do have occupational therapists and speech therapists as well, which are really, really valuable for certain types of cancers. For example, folks with head and neck cancers benefit enormously from speech language therapists. They can help with a lot of the specialized issues that they're experiencing that many other members of their cancer care team aren't able to directly assist with. And so that's kind of what cancer rehab looks like in a snapshot. And I'd say, one thing that's really important, and I think a lot of folks get possibly confused about, is the difference between cancer rehabilitation and exercise. And this can look different depending on where you are in the world. But especially here in the US, I really think about it in terms of specialization. So exercise programs exist in oncology practices, but also out in the community, as well do rehabilitation practices. But rehabilitation therapists are much more specialized and are able to provide really hands-on manual techniques. For example, the speech language pathologists I mentioned are able to do very sophisticated techniques to help with issues like trismus, swallowing, and other common issues related to cancer treatment. So I really kind of think of it in terms of like taking your car to get serviced. If you need some general support, maybe you need an oil change or something like that, the Jiffy Lube is totally fine, right? That's a great place to take your car. But if you really need a new transmission, you're probably not going down to the Jiffy Lube. And that's not to say anything against exercise programs. I myself is an exercise physiologist, so that's my clinical skill set. But I do think it's important to recognize that a lot of patients do need that hands-on specialty care from a therapist who's really highly trained to be able to provide those specialized techniques. And so that's the big difference, and I think the thing to appreciate.
Alina, have you got questions on that as well?
I think Kelley gave a really great overview. Kind of my summary to add would be that the oncology team, right, the physicians, the APPs, they're working to add years to people's lives.
Yeah.
And you could think of rehab as adding life to those years.
One of the things that we did discuss in our prelim meeting was all the rehabilitation that's occurring is post-surgery. Could it possibly happen at the time of diagnosis, for instance? Could rehabilitation start earlier in the journey?
Absolutely, John. So rehab is often still framed as an afterthought, right? Something that you refer to once function is lost. It should really be a core pillar of cancer care alongside cancer treatments. So we often advocate for prehab, which happens before someone starts their actual treatments, because we can anticipate the functional declines and the side effects that they're going to experience. And we could try to mitigate some of those side effects by educating the patient on what they can expect, how they can help themselves, and how we can help walk alongside them, right? And that may look like assessing their baseline measures to understand where they're starting. Maybe we need to get them stronger. Maybe we need to work on their endurance before certain kinds of surgery. Maybe we need to work on range of motion because after surgery, they may need radiation and they may need to get into certain positions that are hard to get into even before the operation. So there are many considerations. We go through pretty systematic overview of different systems when we assess patients for their strength and their balance and range of motion and functional measures to identify where they may not measure up to age-based norms so that we know where to anticipate some decline and provide intervention. And then during active treatment, if someone is going through systemic therapy like chemo or immunotherapy, over a period of months, we anticipate there's going to be a functional decline. And sometimes these issues sort of creep up slowly, right? It's not like you got an infusion and next day it's all over. It sort of builds in your system and it takes months. But if you look at someone 6 months ago versus 6 months later, when you don't feel great, you just want to lay there. It doesn't help with how crummy somebody feels. And getting into an exercise program or some kind of physical activity isn't always top of mind for people who are dealing with, this traumatic experience as many experience it. So
But
yeah, there's absolutely room to intervene early before treatment begins, throughout, and then of course afterwards.
yeah, I love Kelley's analogy about going to Jiffy Lube versus for the quick oil change and grease and then the transmission. When we're talking about long-term survivorship, we're talking about long progressive care. Does that change in the service that ReVital gives patients? How do you plan for long-term survivorship?
So we use something called prospective surveillance. So as patients are doing well, we sort of have a roadmap of how we anticipate things to go. We provide education so they can continue to do things independently and help themselves. And then we set up checkpoints, maybe 3 months later, 6 months later, a year later, so that we can continue to assess how they're doing. And if anything starts to slip, then we can put it on their radar. Hey, we notice your balance isn't as great. Let's start to work on this or that so that we can be more proactive rather than reactive, where
Mm.
someone is declining functionally and now they're falling and now they're breaking bones and coming into the system, much later where it's just so much more to recover.
Is there a difference between advanced disease and newly diagnosed disease, or is the approach exactly the same? For our listeners, is there different types of approach as disease progression occurs versus early progression?
Absolutely. And each treatment, each person is going to get an individualized care plan, right? Depending on what their goals are. Someone might be learning how to live without a limb and, after an amputation and maybe they need prosthetic training. Someone else might be returning to sport and another person, maybe their goal is to have a meal with their family and to have enough energy, to take a shower, to get dressed, and to be able to sit with their family and enjoy that time together. So we meet people where they are at any point because independence in our function, and that dignity matters to people till the very end, regardless of what stage they're in. So we set goals based on what is important for that person at that phase. And sometimes those goals can be restorative, sometimes they can be supportive, and sometimes they can be palliative.
Great answer. And thank you very much for that clarity, Alina. Kelley, we're getting into the evidence of your team's research at ASCO. Found it fascinating. We're dealing with specific patients on this research, STS patients, sarcoma patients. But as we've discussed throughout this episode today, it really means basically all patients, right? The approach, as you both said, is individualized regardless of the disease or the patient's situation. Can you give the listeners here an overview of the poster, what the goals were, how this actually came to being?
Yeah, absolutely, John. So soft tissue sarcoma is a relatively rare cancer. We think about, the common, the breast, colorectal, lung, et cetera. But it has a very high functional burden. So as Alina mentioned, the surgeries that are common in soft tissue sarcoma and bony sarcomas can be amputations or can be other, large scale surgeries where functional burden after those surgeries or functional recovery can be very complex. And certainly has impacts on the person's ability to function as they did previously. So rehabilitation really has an enormous opportunity here to help individuals with soft tissue and other types of sarcoma. But unfortunately, there's very little evidence in this population. Most of our research evidence in the field of exercise and rehabilitation really comes from like large scale randomized control trials, which are typically done at academic medical centers and other facilities like that. And while these trials are incredible and they're absolutely needed to advance the field and to move care forward, what we really focus on in ReVital is understanding real world care. What do these services actually look like when delivered out in the real world community where your friend or your colleague or anyone dealing with cancer might actually experience the services? And so we looked across our national program and identified patients with soft tissue sarcoma that had received our services during or after their care. And what we did is we examined their patient reported outcomes before and after care, and also the reasons why they were coming in to look at what were the most common issues that were leading them to access rehabilitation services. So what we found is some of the common issues, again, were not unique among this population necessarily. So pain and fatigue, weakness and deconditioning, gait and balance difficulties, and also peripheral neuropathy, which is sort of that numbing, tingling, sometimes painful sensation, commonly in the hands or feet and often associated with chemotherapy treatment. So we see that very commonly as well. So that's what sort of folks were coming through the door with. They received treatment for about 1 to 2 visits per week for 8 weeks on average. And then after that treatment, upon discharge, we saw clinically meaningful improvements in their patient-reported outcomes, including their physical health, their physical functioning, and their social functioning.
So what are the results matter in your approach to patients? Did these results impact the program or they just reaffirm everything that you're doing?
Yeah, it's a great question. I think it's twofold. They definitely impact the program in terms of helping our therapist to better understand this patient population. Like I said, this is a relatively rare patient population. I'd say our therapists across the country on any given day are probably seeing the bulk of breast cancer patients just because that's a very high volume patient population. And they often are a population, frankly, that really accesses care especially in a proactive manner. So we see a lot of breast and other diagnoses, but soft tissue patients are what therapists often don't understand is these are really within our wheelhouse as experts in musculoskeletal care and function because that's so ingrained into what their cancer actually is and the treatments that they're receiving. So this information, we're absolutely feeding it back into our therapists to help them to understand, for example, what these patients might look like when they walk through their door, how they might prescribe their plan of care over time based on what we saw in the study, and also the benefits of care that they can expect to see and help to educate their patients on to, again, kind of reinforce the importance of that care, help patients stay engaged. And then the second way that we're using this research is to educate providers. So soft tissue sarcoma surgeons and chemotherapy providers and radiation oncologists. I'm just really trying to use this evidence. Like I said, there's not a lot of evidence in this population. So this is just another way we can advocate for improved access to services.
Yeah, I'm looking at your poster, and you talked about pain and increased mobility, but I think you really need to give the percentages so people can understand what the important improvements were in these particular patients.
So in our study, we saw an average of a 2.5 point improvement in physical function, a little over 2.6 improvement in physical health, 2.6 improvement in ability to perform social roles and activities. And all of these improvements are on a scale of 1 to about 100 on a highly validated measure, where 50 is a US national average, and a 2 point improvement indicates a clinically significant improvement. And what
Yeah.
that means is that level of improvement, based on a whole host of previous research that has been done, is a level of improvement that patients can feel, can experience, can observe, and say, wow, I have improved in this intervention or in this time. And so it's great to not only see significant p-values in terms of research, which just gives us confidence that the improvement that we observed in the study is the true improvement that we might see in this population, but also that the level of improvement was above that of which is indicated to be clinically significant.
Alina, can you give us an idea of what everyday clinical practice now looks like from your approach and your team's approach, knowing this evidence? And I've got one more question which popped in my head. Soft tissue sarcoma in children and other cancer. Can you also talk about the benefits that ReVital bring to those patients as well?
Yeah. And so when these kind of things occur in children, of course, it affects their function in a meaningful way, right? There could be extended treatment periods, missing school, missing social activities, and that interaction that's so vital for children. In addition to physical impairments and inability to participate in sports or activities that make, people who they are. And so we work with those populations, and our focus is always to maximize function, sometimes within limits created by the disease. But for us, it's how do we keep, whether it's a younger patient or an older patient or really any age, how do we keep them functional and as independent as possible, even if we have to modify those activities? When someone can do more for themselves, just emotionally, psychologically, they're more engaged in their own recovery than when you're feeling like you just can't do anything and you're dependent on others. So therapists get really creative. Physical therapists may use assistive devices. Occupational therapists may make, splints or different, I guess, ADL enhancing tools, like if it's to help somebody eat by themselves or dress by themselves or, take care of their basic needs on their own or with minimal help.
So it's a total surround sound service. Is that what I'm
Yeah,
hearing?
and our speech therapists as well as the occupational therapists also address cognitive issues. Sometimes we see cancer-related cognitive impairments, word finding, and it's not like a severe brain injury kind of level, but you've probably heard the terms chemo brain and
Yep.
people feeling foggy and those kind of things. And therapists actually assess and address these types of issues as well.
Next question I have is, in the system of evidence, where do you fit into the multidisciplinary team? How does ReVital work with big hospital systems, the cancer centers or the orthopedic centers within these systems?
I think cancer rehab works best when it's integrated with the oncology team. So you have your physicians, surgeons, radiation oncologists, nurse navigators, other advanced practice providers, dietitian, social worker, and the rehab team is really an additional piece that brings it all together. Everyone has their dedicated roles. Rehab's role is really to help the patient tolerate the medically necessary treatment to maintain that functional independence, as we talked about quite a bit, and to stay connected to the activities that matter most for each patient. We're not separate from cancer care. We're part of the supportive infrastructure and should really be considered at all phases, not just late in the game. So the way that we integrate with oncology teams, because we don't have our own oncology, physician teams, right? We just do
Right.
rehab. We figure out workflows with those teams, those that are truly bought in and want these services for their patients, figure out triggers in whom they should refer to therapy and at which points, and put processes in place with their teams of who's going to identify and who's going to make the referral. And then it's a lot of communication. It takes a lot of communication between the different providers, with our therapists calling to discuss any clinical questions, any precautions, anything we need to be aware of, and to provide updates on how the patients are doing so that everyone stays on the same page. So I think putting processes in place, you know, integrating how these services are used with the teams, and then ongoing communication are really important aspects to making it work.
It's a good segue to my next question regarding patients. How do they reach out and talk about rehabilitation to their doctors or to their multidisciplinary teams? And what symptoms shouldn't be ignored when these patients are talking to their teams? Kelley, Alina?
I can kick it off and hand it
Right.
over to Kelley.
Yeah.
If something has changed in a person's body or their ability to function during or since the cancer diagnosis or during treatment, it's worth asking if rehab would be a helpful referral for them. I think part of the barrier is just knowing that these specialized services exist. And thank you, John, for shining a light on this, on the fact that cancer rehab is available out there in the world, because a lot of people don't know. They think about it when they sprain their ankle. Oh, yeah, go to rehab, they'll help you function. You think about it if someone has a stroke or is diagnosed with MS. When it comes to oncology, a lot of people, it's just not at the forefront of their mind. But how do we treat cancer? We either cut it out, we poison it, we shrink it, or a combination of those things, and then perhaps other medicines, beyond. But each of those have predictable side effects that many of them rehab can improve.
Alina, from the healthcare professionals, when should they be referring and what opportunities being missed in that early referral from your experience?
I think asking if a patient is having difficulty walking or doing any of their daily tasks can really give insight into how they're doing functionally at home. Because sometimes it's just a matter of spending that time to really inquire. If they say, "How you doing? You good?" "I'm good." Right? And then the conversation moves on to the medical. Is it shrinking? Is it growing? Is it, what are we doing? How are we dosing? Sometimes patients will say, "Oh, I'm back to work." And if you just follow up with, "Are you able to do all the things you need to do at work?" That's when they might say, "Well, actually, I have someone helping me open the drawer because I just don't have the strength to do it." Or I have someone helping me bring things from my desk to someone else's because it's really hard for me to walk. And so that's where those functional deficits can become more apparent. It's just asking a few questions.
Yeah, I think that we're all, even myself, we're all sort of scared to ask for help, right? Because maybe asking for help is a weakness, but it's something that patients should be reaching out if they need help, then they shouldn't be scared about asking for it. I see that from a EMS perspective all the time. By the time that we get there, they should have asked for help days before. They've hidden the symptoms or they're ignored it until it's become an acute phase. So I don't know if you see the same.
I think that's a really good point, John. I think one of the important roles of providers as well can be to just normalize rehabilitation. I think rehabilitation can sometimes get sort of a negative connotation for perhaps, in terms of, well, I need help, or I'm not doing well, so I need rehabilitation. And especially in the context of cancer care, where things are so dynamic, things, can be possibly life or death type decision making. There's so much more going on than, for example, in the context of a joint replacement or things like that. And so I think for providers, normalizing rehabilitation in terms of this is something that can help you throughout the journey. This doesn't mean that you are disabled or anything like that. It's just something that can help you to optimize and be at your best. And in terms of, early intervention, there's strong research evidence now supporting also that if we go back to prehab for a moment, getting patients in for prehab so early, possibly soon after diagnosis, actually shows to help patients to be more resilient during treatment. They can better adhere to their course of treatment in terms of treatments like chemotherapy. There's also some research that's been done looking at patients who were deemed previously inoperable for major surgeries, for example, abdominal or lung surgeries. And in those studies, they're actually showing that coming in and receiving a prehab intervention can actually put more treatment options on the table for you. So it's not only about function, although that is our focus, but the impacts of rehabilitation extend far beyond function and could possibly help someone to receive better treatments, endure treatments, perhaps even extend the quantity of years that they have with their loved ones and doing those things that make life worth living.
Yeah, I get the feeling that it's easier sometimes to say, go to a gym and work out and get fit. It's harder to say, look at a rehabilitation center and get fit, before the surgery. I wonder if it's just a mindset thing, is that we think about going to the gym twice a week and, maintaining the health, but we don't think about getting rehabilitation prior to or post until it's really an emergency. And I just wonder if that mindset could change.
Yeah, I think that's a really interesting perspective. There was some research done looking at patients' perceptives and likelihood of purchasing. I believe they looked at like yoga memberships versus going to rehabilitation or like a specialized exercise program. And I can't remember the statistics off the top of my head, but patients were much more likely to purchase a yoga membership, even if when they followed up, they never actually went, than going into rehabilitation or exercise and really working with someone that was specialized. So I think there's definitely something to that. I think it's all about raising awareness, of these services and really how they can be and just trying it. For most patients, especially here in the US and really in other countries, a lot of them have better reimbursement structures, but rehabilitation is often included in your insurance benefits. So a lot of times we're talking about a copay, especially if you're on Medicare. So just try it. Give it a couple of visits and you might feel a lot better. You might feel a lot more equipped. But worst case, you've lost nothing. And this is always something that you can come back to as well later on in the journey if you do find yourself being overwhelmed with treatment or too many appointments. And we do hear that a lot from patients. But our therapists also can provide home exercise plans and other supports, just a lot of things that you can do outside of the clinic that can be very empowering during the process.
So looking ahead, where's the future research and technology go from what you've got today? What's the goal?
Yeah, I think it depends on who you ask. What we're really focused on
Well, I'm
is
asking both of you for the start. You're the experts.
well, perfect. So we're really focused on real world evidence. Like I said, I think we have a lot of work to do, obviously, and in continuing to integrate cancer rehab as standard of care. There's been an enormous amount of progress that's been made in the last decade and the last 2 decades, thanks to a lot of researchers whose shoulders I stand on a lot of times, in addition to many clinicians at ASCO and other major organizations who have really championed this work and this field. So, for example, rehabilitation is now included in pretty much all organizations' major oncology guidelines. So the ASCOs, the NCCNs, we're also included in oncology practice standards from NAPBC, COC, et cetera. So all of that work is really being able to support the infrastructure that's needed to truly integrate these services. So I think that's one big component that we'll continue to need to work on, is how do we implement services in a way that meet those standards and those guidelines and bring forward access, real world access. I think another portion is cost effectiveness. So we need to be able to show to payers and to healthcare systems that rehabilitation and exercise interventions are cost effective. This is a really important area of research that's currently going as well. And then, we've got more and more research now coming out showing exercise specifically is linked to outcomes like survival. So the challenge trial is, sort of been the buzz the last, I think, 2 years now, since it was presented at ASCO. That's our first trial, really showing definitive evidence that exercise, sustained exercise over a long period of time, so 3 years in that study, was actually associated with improved overall survival in a 5-year, 7-year, and 8-year period in colorectal cancer survival.
It's an amazing study.
Yep, absolutely. So I think now the challenge is translating an intervention like we saw in that study to the real world. How do we get interventions like that are very expensive and highly specialized to conduct in the context of a randomized control trial to the hands of patients that need them? So, for example, that study provided coaching support over a 3-year period to patients. And something we commonly see in our practice and in the research is when patients leave our care, when they're doing better and they're discharged, oftentimes they do really well for a while, but then often there might be a little bit of a slide, right, in terms of their levels of exercise. And so what we saw in that study is that sustaining that level of exercise over a long period of time seems to be really one of the keys, right, to obtaining outcomes like survival.
Quality of life assessments were around the 90%. It was just crazy.
Yeah, absolutely. And I think that's a great point too. In the last decade now, we've also seen a huge rise in patient-reported outcomes, both in the research, but also in real-world clinical practice, and especially in oncology. And so, there's this saying, right, what gets measured gets managed. And I think we're really starting to see that come to fruition. A lot of these patient-reported outcomes are focused on things like symptoms and symptom management, a lot of the ones that we've talked about, like pain and fatigue and function. They're often a lot of times focused on quality of life and distress, of which physical abilities can be a big source of distress. So more and more now these outcomes are being integrated into part of routine oncology care, both during treatment and after. And so I think the more that we have those data and the more that providers get used to looking at those data and understanding what to do about those data in terms of management, I think that's more and more opportunity to connect patients with the services they need.
Fantastic. And Alina, from your clinical practice perspective, what's new and exciting and going to be future in the clinic?
I think, cancer rehab is shifting from service delivered just on the end of cancer treatment or when disabilities develop, and really integrating the rehabilitation model throughout the continuum of care, being more proactive. This is something we're really working towards. Next decade, hopefully earlier identification, right, by the oncology teams, more precise referrals, digital monitoring with patients to see how they're doing over time, and if they're slipping, getting them back in, and just continuing to show stronger evidence of the value that rehab brings, as the many points that Kelley specified.
Coming to the end of our session, if you had one point each, what would be your message to our listeners and to the healthcare providers that will be listening to this episode? Kelley?
Okay, I'll go first. I think, to all the patients out there, I would say that there's so much that you can be doing in terms of living well after cancer, and that rehabilitation is a huge tool and asset to help you to be able to do those. And to oncology providers, I think it's just about getting to know their local rehab or exercise providers. There are plenty of tools online for patients as well to help you to access these services and get to know supports in your area. Many cancer centers have their own rehab programs, but many don't. And we work with a lot of those. But there are also many other oncology exercise programs out and available in the community. And I think just getting to know the folks that are running these programs, how passionate, how dedicated they are, how extremely knowledgeable they are about cancer, and the impacts on patients' health and well-being, I think can really encourage providers and build relationships to be sending patients more often and to also build that trust that's so important in knowing that your patients are going to be well taken care of when you do hand them off to someone else in the community.
Great. Thank you very much, Kelley. Alina?
That's a hard one to follow. It said functional goals remain meaningful at every stage, right? You asked about different points in someone's cancer continuum, and to the people or the families dealing with cancer diagnoses, don't just accept all of the symptoms as a new normal. Things like weakness and fatigue and neuropathy and balance and other impairments and pain, those are really things that can be helped with specialized rehabilitation. So ask about those types of interventions. And then for the providers, it's really identifying patients earlier, thinking about person sitting in front of you and what their life and physical demands look like. Because for one person, walking may just mean walking to a park, and for another who has toddlers, it might be walking back with the toddler on your shoulder, the bag, the scooter, and all the things that they brought. And that's a very different, physical demand that they need to be able to perform at. So not only thinking by specific diagnosis or prognosis, but really thinking about whether rehab can enhance the quality of life for the person that's in your care.
Well, thank you very, very much for that. So, listeners, what we've heard today is that cancer rehabilitation is no longer an option. It's not an extra. It's becoming an essential component of comprehensive cancer care and a multidisciplinary team. So I'd really like to thank Kelley and Alina for sharing all your thoughts and expertise, and importantly, the work that you do every day to improve patients and their families. And I hear that you've got a publication coming out soon, so we'll be very excited to have you back on MedInsights Unleashed. And from the bottom of my heart and all the patients and healthcare providers listening to this episode, thank you very, very much.
Thank you so much, John, and thank you to your listeners.
Thank you.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.